Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking about spine pain with Dr. John Reeves of WK Spectrum Neurosurgery. They are the brain and spine specialists. We'll be taking your calls throughout the show, and as a reminder, please make sure you're in a quiet room with your TV turned all the way down before making your call. And you know the number, it's 318-219-4569. We look forward to hearing you about this topic. Thank you so much, Dr. Reeves, for being here today.
Well, thank you for having me.
Sure, we appreciate it. So let's just get right to it. We talked at the break or the tease during the midday about common causes of spine and neck pain. So, and you said there's a long list. It can be anything from wear and tear to specific things. So is there a common thread to having these kind of pains?
It's a little bit hard to answer that question. As we said, that time and gravity and the various movements we all make casually throughout the day wear out. These are joints, and so they wear out over time. Now, some people wear out at faster paces than others. Some people are constructed differently than others, and so the effects of time hit them in different ways. There are a few disease processes. The ones we worry about the most are those patients with cancers, and those cancers can spread to the spine and cause quick devastation, so that's a bad subset. There are other diseases like the inflammatory bowel diseases like ulcerative colitis and Crohn's disease, and the effects of that on the gut can produce chemicals that affect joints, including the spine joints, and they can hurt, and those are usual non-surgical causes. We ask our rheumatology friends and gastroenterology friends to handle that subset of patients, but the list is rather broad.
Yeah, boy, I never even thought about all of those things that contribute to it. You'll hear that certain diseases will affect the spine or move to the spine, but never thought about certain toxins and things that your body's producing that will affect the spine. And I never thought about the spine being a joint. It's a joint.
It's many joints.
Many joints. Even though we see all the vertebrae and we see the way it is, of course it is. That's really interesting too. So it works the same way.
It's a wonderfully engineered part of your body, but it's just a big stack of joints, basically.
And so if someone has an episode of back pain, what should they do? Does it depend on where it is in the back? Do they let it go a little bit? Or what do I do if I have all of a sudden, I wake up one day and I've got back pain?
Well, usually have to ask what you did the day before that could have prompted it. And most often it's a strain. That's a very, very common cause of back pain or intense muscle soreness, and if you can identify something that you might have done, most commonly that type goes away. Just on its own, you don't have to do much of anything to make that go away, other than move, but usually heat and some little analgesics and gentle movements, when it should gradually subside. On the other hand, if you wake up and that pain is extreme and completely unexpected, you might need to call your doctor.
Right. And will it happen that suddenly, or is it something that will gradually get worse and worse? Like if there is, like, do you want to take a specific something like you talked about abnormalities in the spine, diseases, cancers. Is there something like, say I had cancer and it was of the spine, or is something related in another organ, another area of the body, and it moves to the spine? Is it a sudden pain? Will I wake up one day and it's there, or is it gradual?
It can, unfortunately, or can be provoked by something very trivial that you ordinarily wouldn't have thought of 10 years ago. But particularly those conditions like cancer, or in older adults, osteoporosis, for instance. Casual movement, or if you sit down a little bit too hard, or I've had patients bend over to put on a sock and fracture their spine.
Wow.
So there are certain conditions, and most patients know they have these things that can provoke a severe pain with very trivial activity.
And do you see much cancer actually of the spine where it starts there? Or does it usually move there from something else?
The primary cancers of the spine that start in the spine are uncommon. Most often we see that as a result of cancers elsewhere in the body that have moved to the spine.
And does it have to be like in proximity of the spine, or are there certain pathways of certain cancers that just move to the spine?
That answer your first question, no, it doesn't have to be nearby the spine. There are some cancers that do that, but metastatic cancer, it gets in your bloodstream or gets in your lymphatic system, and a seed can get just deposited in your blood vessels of your spine and set up shop there.
Goodness. And is that a pain that is a sharp pain, a take your breath away pain? Is there any are the pains different for something that we need to call you about?
Well, we have these various descriptors of pain that we use, aching pain being what I have right now sitting here, maybe you have, and we can distinguish that. Cancer pains, they're generally, sometimes they're agonizing, and they can go from rather mild to rather agonizing quickly. Sometimes you can't escape the pain. Many more benign forms of pain you can get in a posture and it'll settle down after a while, but some of the cancer pains, for instance, they're there regardless of position, and sometimes they're worse at night. We're always concerned about pain in the nighttime, particularly bad pain that wakes a person up.
Oh, so that's something really to be alarmed. Yeah.
That'd be a red flag.
Because you would think at night you're lying down, the pressure is off. You talk about gravity. You don't have the gravity of standing up, it pulling on anything.
Correct.
Right? So when you're lying in bed and you have that back pain, that's really something to...
It can be a concern. Again, you have to
There's so
put it
much.
into the context in which it's happening. If you know you're a cancer patient and suddenly you develop a spine pain and it won't go away when you lie down, that would be something to talk to your oncologist about, and he can start that process of investigating it.
Yeah, and I've worked with several cancer patients who they're told they always ask, how will I know? How will I know if it is terminal, or how will I know? And then said, well, you'll get this pain deep, lower in your back, and that's usually where it happens. With ovarian cancer, different cancers, and I've with some patients and said that's what they were told.
Well, that's unfortunately one we see from time to time. Lung cancer. It's a fellow today that had it, but I think he's going to do fine. So.
Yeah. And so what are the most common surgeries that you do on the spine? What's the reason for most of them?
Well, the most common cause that I, as a neurosurgeon, have a patient in the operating room is most commonly it's just degenerative spine disease. It occurs slowly over time and the joints wear out. A joint can declare itself as being bad by simply rupturing a disc, which is a common scenario. The padding in between the vertebral bones is an elastic material. As it ages, it becomes more brittle and can get little fissures or tears in it, and sometimes a piece of it will spit out and get into the nerve tunnel and squash a nerve, or in the next situation can squash a spinal cord and provoke symptoms that are bad. So that's the most common cause.
Very painful. When that
very painful,
push on,
yes.
Yeah. And what's the difference in a ruptured disc and a bulging disc? Is it obvious that it bursts?
It's a matter of
tears?
degree, basically. A ruptured disc, as you might imagine, is people envision the jelly donut model where the soft, squishy stuff is in the core comes squirting out, and that's a good general picture of what goes on, but a tear happens in the disc lining and some of that squirts out. That's a ruptured disc. As disc age and as we get shorter with time and settle, the disc commonly will bulge, kind of like taking two pieces of a moon pie and squeezing the wafers together and the stuff bulges out around. That's a disc bulge, and that can provoke pain or not.
Because are the nerves attached, or are they just that close that when a bulging disc can push on a nerve and send pain?
The spine is constructed so it has tunnels, and these nerves, as they come off the spinal cord, goes through the tunnels. The nerves have to go by the tunnels, which go by the disc, so they're bystanders to the degrading joints.
Yeah, and so each nerve will go out to a certain part of the body, and you'll feel this referred pain or the pain all the way down. So these nerves are attached to and affect different parts of the body. Right?
Yes, they have a destination. So you're wired kind of like this building is wired. A nerve starts in a particular place and goes to a particular destination and does a particular set of things. And so there's pain referral patterns, which are pretty good. Those nerves also go to a set of muscles that we check when you come to the doctor's office. One of the foundational exam maneuvers is to check the strength of the muscles and certain patterns, say a C5, which is a neck nerve. It comes out and does the deltoid muscle. So if they have a particular pattern of pain and we check the strength of the deltoid and it's weak, that gives us a pretty strong clue that that nerve is very irritated.
Yeah, all right. We have a caller for you. Hi, Alan. Thanks for calling. What is your question?
Yes, ma'am. I just have stenosis in the neck and the back, and I was just wondering if there was a age cutoff, if you get how old is too old to do surgery.
Well, the stenosis is the word we use for the narrowing of the nerve tunnels in the spine. There's a central tunnel that goes from top to bottom that contains your spinal cord and some of the lower nerve bundles. And there's a stenosis also that can affect the nerve as the exit point. So most commonly that's used if it's in your neck. The importance of that is that's where your spinal cord resides. And depending on, I'm not sure what symptoms you had or what provoked the testing that led you to that diagnosis.
Yes, I was in a wreck about 15 years ago, and I've got disc bulging in my neck and my back, and they're getting worse.
Well, 15 years after a wreck, there could have been some slowly progressive degeneration that happened in your neck over that time. Would you come in with that diagnosis? If it's in the neck, we observe the way you walk, because spinal cord dysfunction has a certain set of findings that we can observe gait. That's why we tap your reflexes, because if it's symptomatic, your reflexes will do a particular thing. You get too active.
Last question, how old it would be too old to come in and have a surgery?
Oh, I don't think there's a top-out age in and of itself if you're in good health. I've operated on 97-year-olds with spinal stenosis.
Yes, sir. Yes, sir. Okay. Well, I will try to make an appointment. I appreciate all your time, and you have a safe day. Thank you very much, okay?
Thank you.
Thank you for calling, Alan. See, it's not too late. He can still get fixed. Yeah, I can imagine that would be a concern, especially something happening in 15 years and you're wondering if there's an age, and because we talk about it being degenerative, and the older you get in age and wear and tear. And
you wear and tear. I mean, some of these things do arrest at a certain phase, but that's why you go to an expert to say, where are you in that process? We see stenosis in spines that have basically fused themselves. And perhaps we don't worry about that patient as much as somebody who has a mobile spine and stenosis at the same time.
So they'll fuse themselves?
Spines can fuse themselves.
Really?
Of course, there's a set of disease processes where it fuses itself, ankylosing spondylitis being one of them. Some of the rheumatologic disorders can auto-fuse the spine, and those are pathologies. But sometimes the simple degenerative processes can fuse or become so stiff as to be effectively fused, and so Mother Nature does it also.
Yeah, so we hear about that with arthritis, all of those.
Yes.
And it will, so the bones will actually fuse together, like you would, because there is a surgery where you fuse them together.
There is a surgical fusion.
Yeah.
The problem with some of Mother Nature's fusions is she lays down the fusion bone in the tunnels where the nerves live. So again, as you learn these things, as you do your career, you learn certain patterns, and you learn to assemble all this information and running through your filters you have built into your mind by now, and try to figure out a person's risk factors.
You just figure it out. That. Yeah, it's all individual. So if someone comes to you and this has happened, they're fused together, this has happened, is there anything you can do for them if they're in pain from this Mother Nature fusing their bones together?
Well, if the bones are already fused, you often look at the next door neighbor joints that aren't fused, because sometimes that's the problem. Whether we do that surgical fusion where we apply and get a patient's fusion to heal, if they come back a few years later, it's often not that fused segment. It might be the next door neighbor joint that was not included in the fusion. The same principle holds for those patients who spontaneously fused. There'll be a little segment that Mother Nature fused, and then it's the next door neighbor joint that is provoking symptoms.
Mm-hmm. And that's something that happens over time too. We talk about people just living with back pain and other, and then we'll have arthritis or the other conditions that you just mentioned. There will be all kind of, arthritis and rheumatology that you refer them to the rheumatologist when it's one of those types of situations. But there are all kinds of things that are going on there.
Yes.
That can happen in the spine.
Well, some of these, things that where Mother Nature's one,
Yeah.
if it's associated with the disease process, like ankylosing spondylitis or some of the spondylitis conditions that come from the gut diseases, they have a set of medicines, and we don't like to get those treated surgically because sometimes we're making a mistake if we operate on those patients. So many of the rheumatology medicines are to prevent that spine from fusing.
Mm-hmm.
So it's an interesting.
Yeah, just in figuring it
Opposite,
out.
yeah.
Path. Yeah.
Yeah.
So it's how interesting. It's and so there's non-surgical ways to treat too. And would that be?
Yes, just going back to the most
Yeah.
common degenerative patterns, ways to treat back pain. If you present and you don't have a dangerous or ominous condition that justifies or requires me to say we just need to set stuff aside for surgery, that doesn't really happen really often. We'll send you to physical therapy. Start getting into condition, because that's a huge causation of persistent pain. As patients get a pain, they become idle, they get weaker than they were already, and sometimes just simply re-strengthening helps. We have colleagues in what's called pain management who do injections in various joints. If they can get the needle to the hot spot, sometimes that helps, and use that as an adjunct to your physical therapy. And of course there's chiropractors and there's acupuncture. I don't know as much about those specialties, but the whole goal is to get people more functional.
They all work together.
That's right.
And so do you find that people they'll go to the chiropractor, or they'll have the shots, they do all of this, and then they'll ultimately end up with you for surgery? Or sometimes, when you see someone, have they maybe gone through all of this? Or is
Very
it two different
commonly,
things?
you're kind of the court of last resort. So they've tried everything, and then they present to you to see if they have a condition that will lend itself to surgery, or sometimes they make the decision you need to go back to therapy and try a little harder.
Yeah.
And get a little stronger.
Okay.
Things like that.
Yeah. All right. And we have another caller, but I'm sorry, what was the name again, Zoe? Okay, Foster. Thanks for calling. What was your question?
I have a terrible back. I've had 2 different spinal fusions in my L5, L4, 5, the lower spine, and from the bottom to the top of the third spine. Let me turn my TV down, please.
Okay, we'll wait.
I have had spinal fusions in my L region, at the bottom 2 regions of my spine. And it seems to be just creeping on up my back. And I'm 82 years old. Don't know whether surgery would even be wise to consider, but I have a lot of back pain. I have a lot of gastric issues, which I think causes some of it. But I just don't know what is what there. But I don't find any medications short of like the prednisone, which I cannot take, things like that will touch nerve pain. I can sit and stand, but when I lie down, that's when my pain starts. And I have a band of pain that goes underneath my ankle on my right foot, all the way around the back of my heel. that is like I have been burned. And it's extremely painful and much worse when I lie down. Can't wear a shoe that, or let let hem of my pants legs or anything like that touch it. I don't know what to do at this point, but maybe you can help me.
Well, I'd be happy to try. I'm sorry you're going through all those things, but it's a common exemplar of what we see daily in the office practically. We take stories like this and see if we can correlate that with the anatomy books, and see if we can correlate the anatomy books with what we're seeing on the imaging, and then see if we can come up with a plan that'll help, which might be surgical, it might be a well-placed needle, it might be doing a short circuit of pain pathways by putting in a spinal cord stimulator or something like that that can just kind of yeah, but you really have to take an individual assessment. I can't diagnose you over the phone, so you just have to look at everything.
But it sounds like something.
Sounds like she's having some problems.
And there might be some options for her, right?
There should be some options.
Other than that, I like to do my own housekeeping. I like to do all the, cooking and that kind of things. And I have other issues that are going on that probably don't have that. I've been told I have a lot of inflammation. Would that be probably part of the problem?
Well, if you mentioned prednisone giving you relief, so something inflammatory is going on. But I'd encourage you to stay as active as you can, because once you sit in that chair and get weaker and stop doing things, and that just makes the situation worse. So try to stay active.
I'm not going to make it worse by going ahead and bending, and I'm a clean freak. And when I clean, I like to get it all.
Well, my general advice is to stay as active as you can.
Okay, because I didn't want to make it worse. But and I have one more question. When I had my first back surgery, my spinal column was the doctor said you couldn't have gotten a straight pin down into that area, and they ripped all that out. Could that be part of it too?
Well, again, you'd have to kind of assess things. If you did well with that operation for a long time and then developed symptoms later, then probably whatever that surgeon did fine, and now something else has come up. If you never got a single bit of relief out of the operation and what was done, then you have to look at the whole case and see if you even had the right diagnosis.
Okay, and you mentioned spondylosis.
Spondylosis. Spondylosis is the doctor word for spine arthritis.
Yeah.
Oh, okay. So it's just don't get any older, huh?
Oh.
We want you to get older, because the alternative is a little more drastic.
That's right.
We want you to keep, doing those chores and being happy about all that cleaning you're doing.
That's right.
Does that answer your question?
Yes, it does, and I thank you for your help. And if every time anything that will touch nerve pain,
there's not, when you get to a certain state, there's a lot of medications by mouth are ineffectual after a while, and that's part of the trap, is people keep chasing with medicines, and they'll get some relief for a few days, and the effect of those medicines wear off, and then you've got another problem of too many pills. So you probably need to see someone and see if there's anything that can be done besides oral medications, because those are only so good, and there's sometimes I tell patients there's not a pill in the pharmacy that'll ever get ahead of this.
Yeah. Does that help? Oh, we've lost her. Okay. Well, I guess you answered her question. That was very thorough.
So.
Really nice to hear that. And it's interesting that she started with saying that she feels like it's creeping up her spine. Is that a feeling does that happen, or is that just a feeling that will happen after you have that
Well, that's something we call adjacent segment disease.
Right.
That's usually something that or can happen adjacent to the next door neighbor joint to a
Sure.
fusion. In the grand scheme of things, it happens to the minority of patients, but they're very vocal. So,
So is there anything, any lifestyle or anything that we can do that will affect whether we get neck and back pain in the future? Is there anything we can do to put that off or feel as healthy as we can for as long as we can?
well, I'm an advocate of exercise. I think the stronger a person is physically strong, the better you age. So it has health benefits beyond your spine.
Right.
But I would say if you're in shape, stay in shape. If you're out of shape, then if you can safely start an exercise program. If you're woefully out of shape, then you might need the help of a therapist and a trainer. I think people who aren't used to exercising, I'll usually tell them to get a therapist or a trainer to help, because you can injure yourself in the gym by being a little bit too enthusiastic, or
Right.
simply having bad form and not setting your feet right. So physical strength is very important. I ask patients frequently, do you exercise? And they're either telling me something that they were exercising a few years ago and haven't exercised for years, I
did once.
And some people say, well, I walk. Your cardiologist likes you walking, but your spine surgeon wants you getting physically stronger, and you don't get a lot of physical strengthening out of merely walking.
Yeah. And we talk about the core a lot, that
Yes.
building your core, strengthening your core is really good for your back. And so that is these abdominal muscles, these really help strengthen your back. Is that true?
That's true. It's part of a good total
Good
body
basis, good
exercise
foundation,
program. Should
yeah.
include strengthening the diaphragm at the top of the core, the pelvic floor is on the bottom. So for ladies, you do your Kegels, and men can do Kegels too to strengthen that. Then the abdominal wall is the front of the core, so the variety of abdominal strengthening exercises that don't include sit-ups, which are hard for many spine patients and are hard for obese patients to do. And then finally there's the muscles of the spine itself. So it's really a all the way around and all the way over top to bottom.
Right.
That's the core.
And posture, and again, just be careful with those exercises. Don't go a little too far. And a trainer is, if you really are focused on strengthening your spine and those muscles that support the spine, a trainer probably is a very good idea, because your posture and your form, I would think, is really critical for that, like you said.
It's very critical. So I encourage people there's you see these folks who get their certificates in training,
Yes.
and they're well trained. You talk to them, and they'll guide you. They don't want to have a client who won't come back, so they'll gently push you along. And a lot of people have to be pushed into getting stronger, but I would use the local trainers. I'm sure 99% of them are just fine.
Yeah, definitely. And are there things we can do, like just while we're sitting, like sucking in our stomach, or watch our form? If we are avid walkers, then maybe walking is our choice. There's form that can, we can focus on our core while we're walking. We can suck on our stomach. We can do other things. We can focus our mind,
some of that's
right?
done reflexively, but sucking in your core. But of course, some of these stenosis patients, their problems, they can't walk very far.
That's right.
Their legs
Yeah.
peter out on them, and so
Yeah.
that goes back to the treatment. Things
Yeah,
that need
it's just
treatment.
how much you can do, because
much can you
stenosis.
walk?
Yeah, when we talk about stenosis in the neck, can lead to numb. Your legs can be completely numb, right?
And discoordinated.
Yeah.
Some of the stenosis patients can still exercise, so a bad lumbar stenosis frequently can do weightlifting. They can do exercise bikes. They frequently do very good on those things.
Yeah, so there's always something you can do, probably. Yeah.
Most often there's
Most
something.
often, yeah. Okay.
Yes.
Well, is there any one thing that you'd like to leave us with before we have a few more seconds?
I
Just
think we've covered
exercise.
everything.
We did.
Exercise.
This was
Get
wonderful.
good sleep.
Yeah, get good sleep. Take care of yourself. Drink lots of water.
Water's always
Yeah,
good. Sure.
All right, and just pay attention to those neck pains and back pains, and don't be afraid to call about it when it happens.
Don't be afraid
Yeah.
to ask for help.
All right. Thank you so much. It was
Thank
a
you.
pleasure meeting you. Thank
Nice
you
to meet
talking
you.
about all of this. We really appreciate it. And everyone, thank you so much for calling our callers, and thank you for watching. We'll see you next time on Healthline 3.